Yes.
Before we turn to treatments for liver disease and for the viruses themselves, can I just touch on what you say in your report at page 28 under the heading Prognosis and Life Expectancy? Now, you've already addressed a number of these matters in your evidence, but just a couple of points. Firstly, earlier in your report, you've explained that both hepatitis B and hepatitis C are leading causes of mortality worldwide, more so than malaria or HIV.
So that's correct. I mean, I think it's similar sort of magnitude. If you look at viral hepatitis as a whole, we think there's probably about 1.4 million deaths each year, and there are probably about 350 million people actively infected, and the number of deaths attributable to viral hepatitis is similar to HIV and certainly higher than malaria. And that, in some respects, reflects progress in malaria, which has been lacking in viral hepatitis.
You've identified in your report that, in general, death certificates tend to underreport deaths due to viral hepatitis. Is there any reason for that you're aware of, or any guidance about when death certificates should record hepatitis?
I mean, this is obviously a really important issue, and I think we heard on Monday in particular a number of pieces of evidence about how that can be dealt with in the real world. The guidance is very clear, in my understanding. I think others will confirm that if viral hepatitis is related to a death, it should be on the death certificate. And I think generally, historically, there have been different issues with that, more related to HIV, but I think also to hepatitis, where, for example, you may be involved in managing a patient where the diagnosis has not been disclosed to the family, where it becomes quite difficult, which is not to say it shouldn't happen, but it can be difficult to have those conversations with family after death. And sometimes there are reasons that it's easier not to put things on a death certificate, but that's very clearly not what should happen. There can also be issues about attributing a death to a virus when patients often die of other things. And so causality can also be a question in terms of how that death certificate is filled out. But I think the guidance now is very clear about what should happen.
That also assumes that they died from consequences of the infection. If they died of other causes,
yes, of course.
Clearly there was a large population that didn't know they had it historically. Therefore, you might well be attributing it to other causes where it wasn't known that was the cause. So you could also underreport in that regard.
You explain in your report the difficulties of estimating the prognosis and life expectancy for an individual for reasons you've already touched on, and you've set them out in your report. Can I just ask you to deal briefly with two studies that you do reference in the report, an Australian study and a Dutch study, and if you could just briefly relate what those found.
Yes, I think it's fair to say that we haven't provided a comprehensive review of all of that literature, but it actually was quite difficult to find a lot of data to really give robust estimates of what it means in terms of life expectancy. And as you say, the couple that we could find that seemed more relevant was a study from Australia where there was a very clear reduction in life expectancy on average across a group of patients by about 6 years. And that was taking out other causes of death. For example, as Scott was just saying, often there are many other reasons people die, even if they have a chronic virus. And what you want to try and understand is the effect that virus is having. So if you take out, and this is talking about a general population of hepatitis C patients now where injecting drug use is more common, then you want to try and subtract out that component to understand the effect of the virus. And that was what they tried to do in the Australian study. And the Dutch study, I think you mentioned, of haemophiliacs, found that there was a similar life expectancy to those who got HIV, but there was a very substantially increased mortality related to hepatitis C in that group compared to a general population. And the challenge always in these studies is to try and match that population as well as you can. But I mean, I think very clear evidence that there's an excess of mortality there.
And the way you described it in the report in relation to the Dutch study was those without hepatitis or HIV co-infection had a similar life expectancy to the general population, but those haemophiliacs infected with HCV had mortality rates 16 times higher.
Yes, thank you. That's the correct phrasing. Yes, sorry.
I think it's important to stress that this is the
Yes.
untreated impact, and it's not now the expectation. And the mortality rate, it's the increase in the rate. The rate overall was low. It was higher with hepatitis C, but the rate was still low, and therefore 16 times higher, while it sounds dramatic, is not a very large number of people that would be dying from their hepatitis C early.
And I should just say, because some of those sitting behind me have asked for copies of the Dutch study, that is being disclosed on Relativity, so core participants will be able to have a look at that.
And sorry, just one other point that might be helpful is that clearly, as we showed earlier, a lot of patients with viral hepatitis live in Southeast Asia, for example. And so some of the bigger studies come from that region, but it's difficult to extrapolate what that means for life expectancy in a region like that where there are other competing causes of death. And so I think we have to be a bit careful about transposing that.
Yeah, we would be very hesitant in any context of medical care to translate. You would make far too many assumptions about other socioeconomic factors and other multimorbidities and other comorbidities that might affect the... Oh, sorry. Apologies. You would make... we can't do that in other aspects of medical care. We don't translate prognosis absolutely across to other populations because there are multiple other factors which can affect that with regards to socioeconomic health and other comorbidities where very famous examples in epidemiology of, for example, Japanese post-World War II moving across to the USA, and it wasn't the genetics that determined their life expectancy, it was where they lived. So that's reasonably well established in other areas.
Could I just understand and have on the record so that others can understand what the 16 times relates to? It's a rate over what period?
So the rate is over the lifetime of the study, and
well,
so
everyone dies over a lifetime.
yes, and so it's an age standardised mortality rate, and so if you think of that, because everyone dies over a lifetime, the age standardised mortality rate, there will be very, very few deaths in the healthy people, let's say aged 30 or 40 or 50, and in those who are hepatitis C positive, there would be several more deaths. Because of the way the age standardised mortality rate is worked out, it would look like a very large fold increase. So if there was one person dying at the age of 30 in the study in the control population, and 5 dying in the of the same age in the intervention arm, it's still only 5 deaths out of the 1,000 people, but the age standardised mortality ratio for that would be a factor of 5 or 10. Whereas if it's 50 people dying at the age of 50 in the control arm and 100 people dying at the age of 50 in the other arm, it would only be an age standardised mortality ratio of 2. And so it looks, so it's while it's the correct way of doing it, it sounds very dramatic, but it does depend, and clearly there is an excess risk of hepatitis C, but it makes it sound like a death sentence, which it's not. It's the way the statistics work. So that's the point I was trying to make.
And it's the clear distinction between absolute risks and relative risks, and often in public discussion of risk, those are blurred. And as you're saying, the relative risks can sometimes be used to try and exaggerate what might be there. I think for this particular study, it would be possible to go back to that study, and they do have those absolute rates and in both groups, which may be more helpful. I think it just illustrates that between different studies, the risks are expressed in different ways, and that can make it quite hard to sort of synthesise a single figure, if you like.
I wanted to move on next to the question of treatment. To start with treatment for liver disease, so for liver cirrhosis, liver failure, liver cancer, and then turn and look at the treatments, and in particular the side effects and adverse consequences of treatments for hepatitis in the interferon era. So starting with the treatment options for cirrhosis and liver failure, you've set out in your report the treatment options in relation, first of all, to ascites. And I wondered if you could perhaps summarise those for us. Tell us what the condition is. Many here will know from first-hand experience, sadly.
All right, so ascites is one of the symptoms which develops when the liver function is impaired, and there is fluid which collects within the abdomen surrounding the abdominal organs and may also cause some swelling in the lower limbs as well. Liver disease is one of the causes of this condition. It can also be caused by heart disease or kidney disease or cancers that are affecting the abdominal organs. In a patient who develops ascites, then there is a stepwise treatment, which starts off with advice about general measures. The fluid retention is driven by salt retention, so restricting dietary salt intake, giving tablets which help the body to get rid of the extra salt and water, and this may be all that's needed for many patients. If they don't respond to these treatments or have some side effects which might be affecting the blood salts or an adverse effect on the kidneys, then they are termed as having refractory ascites or resistant ascites, and the next level of treatment should be considered. The fluid can be drained off, especially if there's a large volume of fluid. This is merely to relieve the symptoms. It doesn't stop the fluid from reforming, and drainage may be required to be repeated at regular intervals to treat that symptom. And then if sometimes there may be something else which is damaging the liver, so general advice such as avoiding alcohol or any other factor would be given. And if the ascites remains present despite these simple measures, then there are a number of other treatments that can be considered. So for someone with ascites who's not responded to regular treatment, it's important to ask whether they would be a suitable candidate for a liver transplant, because this will give the best long-term outcome in suitable patients. There may be a number of reasons why somebody might not be suitable to have a liver transplant, and there are two other main treatments that are given for this. So I've outlined one which is a shunt, which can be placed inside the liver, which reduces the high pressure caused by cirrhosis and can lead to reduction in the volume of ascites. That's called a TIPS shunt. This doesn't stop the cirrhosis being present, so that patient may still go on to develop further complications of cirrhosis. And in patients who are having regular paracentesis, this is quite a burden. It requires hospital visits, and patients may prefer to have a catheter which is placed in and remains in place, and then the fluid can be drained off regularly at home. And this is a relatively recent development for the treatment of ascites. Recent development.
Then you've next considered varices. Mm-hmm. Can you again briefly explain what that is and then outline the treatments for us?
So varices is used to describe large varicose veins that develop when the pressure caused by cirrhosis in the blood which feeds into the liver is increased. There are veins, the normal circulation is that all the blood from the stomach and the intestines will flow together into a vein called the portal vein, which then goes into the liver. Then the blood goes through the liver and then returns to the heart via the hepatic vein. And when someone has cirrhosis, the pressure in the portal vein increases, and that pressure feeds back to these venous channels present in the intestines, and they can enlarge and become under high pressure, and that's when they're called varices. The risk, when the pressure increases in those varices, there is a risk that they may bleed spontaneously, and somebody would not likely know that they had varices until such an event happened, unless a test is done specifically to look for those. The test that is done to look for those is endoscopy, which is where a camera is placed through the mouth into the stomach. Under direct vision, the esophagus is visualised, and these varices can be seen. So most guidelines would recommend that if someone has cirrhosis, that they have one of these procedures of endoscopy. And if no varices are present, then it would be normal then just to repeat the test as a screening test in 2 to 3 years. The risk of bleeding relates to the size of the varices, so if small varices are noted, again, there's no specific treatment recommended, but monitoring to reassess at an earlier interval. And if somebody has medium or large varices, but they've no history of bleeding, then there are 2 treatments that can be offered, either medical treatment with beta blocker medication, which reduces the pressure inside the varices, or to place rubber bands which tie off the varices and stop the blood from flowing through them and reduce the risk of that.
And if it gets to the stage of variceal bleeding, that is an emergency and a life-threatening
So
condition.
if patients with cirrhosis, I would normally warn them that if they were ever to experience symptoms such as vomiting of blood or passing blood in their stools or dark stools, that's an emergency and they need to attend hospital straight away. And they may need blood transfusion, supportive treatments. And endoscopy is done in that situation to try to stop the bleeding, which is usually done by placing rubber bands or injecting the varices with glue to stop the blood flowing through them.
And then the next complication that you've discussed is hepatic encephalopathy. Could you explain how that might be treated as well, please?
Yes. So one of the jobs that the liver does is remove toxins from the blood which are produced by gut bacteria. And so either if the liver function is impaired, this process may not happen correctly, or because of the cirrhosis, the body may develop channels that take the blood away from the liver, so the toxins are not getting to the liver to be removed. And it is a symptom that can be brought on by any other illness. So it may be something as simple as being dehydrated or constipated that leads to this symptom. And it can start off as mild with just simple disorientation and confusion, and then it can progress through various stages, where the most advanced stage is effectively a coma, where the patient may be unconscious. And in the milder symptoms, this can be managed at home with medical treatments. But if somebody's unable to be cared for at home, or they've got more serious encephalopathy, again, they should be admitted to hospital. And the other causes can be things like variceal bleeding or infection, so these should be actively sought for and treated if they're present. To prevent encephalopathy, the first-line treatment is a drug called lactulose, which helps to prevent constipation and reduce the production of toxins by these gut bacteria. But if patients are still having symptoms despite that, there is a drug called rifaximin, which should be prescribed if patients are having recurrent encephalopathy.
And if that's refractory to medical treatment, again, that's an indication for liver transplantation. And then can I ask you just to tell us a little about liver transplantation? We've heard evidence from those who have undergone that surgery. We've had evidence from those who've undergone it and ultimately not, from the relatives of those who've undergone it and ultimately not survived. So again, it's an important issue for many people.
Certainly. So in the UK, there are 7 liver transplant centres, and liver transplantation is regulated by NHS Blood and Transplant, and there are policies in place for the assessment of patients for transplant and for the criteria which patients need to meet in order to be suitable for a transplant. And all the centres would work to those. And again, this has evolved over the time that the inquiry is interested in. So these policies are also freely available via the NHSBT website if people are interested to look. So there is each transplant centre has a network of referring hospitals, because patients may be referred to us from very far away. And when we see patients who have had an episode such as a decompensating event, and they have not responded to the usual medical treatment, then these are the patients who should be referred to their transplant centre for consideration, as long as there's no other obvious reason why they might not be fit for that to happen. The process of transplant assessment it involves many different medical professionals and allied health professionals, and what we are aiming to do is to try and establish the severity of the patient's liver condition to ensure that it meets the criteria set out in order for that patient to benefit from a transplant, but also to look at their overall fitness, which may be due to other health conditions or their frailty or several other issues that may impact on their outcome after a transplant. And so if the patient is deemed to have a need for a transplant and they're fit enough, then they would be offered that as a treatment.
They would be placed on the transplant list, presumably.
That's right.
2018, you've described over 1,000 liver transplants being performed in the United Kingdom. And the estimated survival rate 1 year after a liver transplant is over 91%, 5-year survival over 80%.
Yes, that's correct. I should also say that we're talking about decompensated cirrhosis as a reason for transplant, but there are other reasons. Yes. For example, early stage liver cancer or some of the other complications of cirrhosis which are rarer but listed on the policies that I've alluded to. I'm happy to talk more about these if that's relevant.
Can I turn to liver cancer and the treatment options for liver cancer? And again, you've set it out in some detail in the report, but if you could summarise those for us, that would be very useful.
So there's three, as I mentioned before, most patients with liver cancer already have cirrhosis as well. And so most centres will use a guideline which involves three main factors. One of these is the stage of the cancer, that is the size of it and the number, because liver cancer may be multiple within the liver. Secondly, the severity of the underlying cirrhosis. We talked about the Childs-Pugh system and the presence of decompensation. That's important because if someone has decompensated cirrhosis, they won't tolerate some of the treatments very well. And then thirdly, performance status, which is a common parameter in cancer treatments, where it really describes the overall level of physical functioning. So someone who is undertaking normal activities would have a performance status of 0. Someone who's very frail and unwell, spending most of time in bed, would have a performance status of 4. And that's summarised in the picture on figure 1511B, where there's a staging system which is commonly used by many centres and originates from the Barcelona clinic.
Page 33 of the report, please, Henry. Might come up to 35. Thank you. It's the top half of the page.
So what this algorithm outlines is the stage according to these three factors which I've mentioned. And from the left, stage 0, moving through to the right to the more advanced stages. And then you follow through the algorithm looking at the different factors which I mentioned. And on the early stages, the three treatments which are associated with the best long-term outcomes are of approximately 40 to 70% 5-year survival, is liver resection or removal of part of the liver with a cancer in it, liver transplantation, and in this picture, RF or PEI are techniques which are in the report are thermal ablation or ablation, which is a local treatment for the cancer. And then moving to the right, the patients who have intermediate stage, so they may have larger cancers or in multiple parts of the liver. The treatment applied there is called embolization or chemoembolization. It's blocking off the blood supply. In contrast to the treatments on the left, embolization is not considered to be a curative therapy, but may prolong survival and may prevent cancer progression. Moving further right to the advanced stage, stage C, this is where drug therapies, particularly over the last 10 years and even in the last 2 years, there's been a great deal of progress made in systemic therapies for liver cancer. The drug listed here, sorafenib, was the original drug shown to benefit survival in people with advanced HCC, but the overall survival is still in the order of months, even in patients who respond to treatment. And then furthest to the right, patients who may be very frail or with poor liver function would not be expected to tolerate any of these treatments well, and palliative care or supportive care would be given here.
And I think you identify somewhere in your report that in the United Kingdom, in common with other parts of the Western world, liver cancer is generally only identified at a late stage.
That's right. There are two factors that influence that. So first is that many patients don't know that they have cirrhosis, and they may be diagnosed with cirrhosis and liver cancer at the same time when they develop symptoms of the cancer, and then it's usually diagnosed at a more advanced stage. The surveillance for cancer in patients with cirrhosis we've mentioned earlier, and that people who are under a surveillance programme are more likely to be identified at an early stage, but this is a very variable tumour, and some patients, despite screening, may still be diagnosed at a late stage, even though they've been undergoing tests.
Can I then turn, please, to section 15.13 of your report, where you begin to examine the different treatments that have been provided for hepatitis B and hepatitis C over a number of years. I'm going to spend most of the time looking at interferon for reasons that I think will be obvious to everybody in this room, and the side effects and adverse events associated with interferon. But could I ask one of you just to talk us through first briefly the treatments that have been available for hepatitis B and what treatments are currently available for hepatitis B?
Yes, and I think, again, to emphasise that the objective of treatment is different for hepatitis B and C. And it's probably helpful to start with interferon, which was really one of the first drugs used for hepatitis B. Now, in contrast to hepatitis C, the objective of using interferon is not to get rid of the virus from the blood necessarily. But there are a small group of patients who can benefit from treatment which will turn their virus from being very highly active into a lower active state, which is better for the long-term condition, and which can then lead to benefit from the other treatments. In general, because as has been well recognised, the side effects from interferon are unpleasant, and in the setting of hepatitis B, treatment would often be for 48 weeks. And the success of that treatment may be very, very low, under 10%. It's generally not used, although it is recommended as part of NICE recommendations for therapy. It's rarely used. And so the mainstay of treatment now, and indeed for the last 20 years or so, has been what we call oral nucleoside or nucleotide analogue drugs, which directly target the virus. And the first of those that was used widely was lamivudine, which we'll hear about tomorrow as well, I imagine, because it's also a common part of HIV treatment. Lamivudine is generally a very well-tolerated drug. It has a relatively good side effect profile, certainly nothing like interferon. And it was used for a number of years, and there may still be patients taking it today where it's working. The main drawback of lamivudine is that many patients would fail treatment within a few years with quite a high rate of resistant virus emerging quite quickly, in the order of maybe 50% of patients within a couple of years. So it was good when it worked, and as I say, still is used occasionally, but it's generally given way to other treatments which are more durable. And the first of those being adefovir, which we don't use so much now, but again, there may be patients on it for whom it's working well. But the drug that followed adefovir, which is a bit like it, which is tenofovir, of which there are now two forms, TDF and TAF, which are the mainstays of treatment that we have available. Tenofovir, disproxyl fumarate TDF is probably the most commonly used drug. It's a once-daily drug, again, also active against HIV and a lot of experience with it with HIV, and a much lower rate of emergence of resistance with that drug, which means that many patients can manage to take that on a daily basis indefinitely and control their virus, and their virus becomes undetectable in the blood. And the side effect profiles of that drug are relatively good. There are some important and well-recognised side effects, including effects on the kidney and potentially bones, for example, but compared to other treatments, generally well tolerated. And there's an alternative first-line treatment which we would use now, which is entecavir, which is occasionally used, which is again another oral daily medication which has got a relatively good side effect profile and is effective against suppressing hepatitis B. So at the moment we really have those two drugs as our main choices, and we have this newer version of tenofovir coming through, which is not fully approved due to costs particularly, but which may have advantages in a better side effect profile for patients who need to be taking this medication long term. And the drugs we have now are generally, when they're taken on a daily basis, very effective at suppressing the viral replication. So again, not getting rid of the virus completely, but certainly clearing it from the blood and allowing, be it the liver to recover or other manifestations of the infection to improve. By controlling the virus, it leads to longer-term clinical improvement.
And for those with hepatitis B who are on these treatments, because the aim of the treatment is not cure, it's not clearing the virus, it's not a time-limited treatment. It's a treatment that you remain on. Is that right?
So in general, yes. I mean, in general, you would usually say to a patient, you would need to expect to stay on this lifelong. There's a lot of work going on to identify. Not everybody goes on to treatment for hepatitis B, that's worth saying. So there's an assessment at the start to see which patients really need to. But once you start, generally the case is that you carry on. And that can, in some cases, be reviewed, but that would be relatively uncommon.
And then just briefly with hepatitis D, delta hepatitis, you say their treatments are very limited, and pegylated interferon remains the mainstay of treatment.
That's correct, and we heard earlier that this is particularly important where you have both infections and that there is probably a more aggressive clinical course to that. Treatment with interferon can lead to what we would call virological response, but often that's not carried on once that treatment stops. And so it is an area of active research, and there are some potentially useful drugs coming through that might help with that, but it's a relatively difficult condition to treat at this point still.
Turning to hepatitis C, Henry, could we have up from the report the figure that's on page 41 of the report, please? So before we look at the side effects and adverse events associated with interferon, you were going to talk us through this figure.
So we thought this would be a helpful figure to illustrate a number of different issues, and I think some of them we've touched on already. And as you say, here we're really just looking at the cure rates. And so for those who are not familiar with the terminology, one of the challenges, as many people will know, of knowing whether you're cured of hepatitis C is that it's very hard to tell when you're on the treatment. It's only when you come off the treatment you can be monitored, and we can see if that virus returns. And so generally what we do now is to monitor a patient who finishes for 12 weeks, and if the virus is still not detectable in the blood after that point, we call that a sustained virological response at 12 weeks, which is shortened to SVR12. So we throw around the term SVR12, and really we sort of use that as a surrogate for cure. And so what we see in this graph on the left-hand side is SVR12 rates. And I think the first thing just to emphasise is how those rates have changed over time. So on the left-hand side, we're looking at the first treatments in 1991 through to where we are now on the right-hand side. And you can see really those early treatments with either 24 weeks or 48 weeks of interferon were offering very low treatment cure rates. And so it was a really difficult decision about whether it was even worth having treatment given the prolonged nature of treatment and the success rates. And I think that also emphasises what we talked about earlier, which is the difference in genotypes. So the black bars here being genotype 1 and the purple bars being genotype 3. You can see there was quite a distinction in those early days between how you would respond to those treatments depending on that genotype. And then we moved through an era where we had interferon, but we added ribavirin into that interferon treatment. And you can see that improved cure rates quite significantly, and we'll come on to the consequences of that in terms of side effects. And with the advent of pegylated interferon, PEG in the graph here, again, the cure rates improve further, particularly for the genotype 1 infections, but also for the genotype 3 infections. And then around 2011, we move into this new phase of treatment for hepatitis C, where we started to get these new drugs called directly acting antivirals against the virus. And that's to contrast with interferon, which, so we haven't really mentioned this, but interferon is a product made by the body naturally in response to infection. And when you get flu, for example, interferon is something that's produced, and that's why often you get those symptoms from interferon. That's what that compound does. But these newer drugs target the virus directly rather than the body. And the first generation of those from 2011 onwards were specific to particular genotypes, in particular genotype 1. So you'll see that those cure rates for genotype 1 improved very significantly, but the genotype 3 cure rates didn't change at that point because those new drugs only had very specific activity. And then what we've seen in the last 5 years really is the advent of a wider range of these directly acting antivirals, which have managed to achieve very, very high cure rates, as you can see in the region of 90% plus, without using interferon. And that's what we're now calling the interferon-free DAA era. And really, the development in the drugs in the last 2 or 3 years has been to have drugs which are better against all of the genotypes. So whereas we used to have drugs that were very specifically genotype dependent, we now talk about having pan-genotypic drugs, which are not always available everywhere, but that's where we are now. And really, I don't think we expect to see any changes in hepatitis C treatment in the foreseeable future. This has moved incredibly fast, but has kind of matured, and we now have a range of options available. I don't know if anyone wants to add to that.
I think to put it into the context of the discussions that were being had with people affected by hepatitis C as that timeline evolved, clearly as we had interferon ribavirin available, and particularly when the interferon became pegylated, we had therapies that were curative. And at that stage, we were aware of the natural history of hepatitis C and how it was progressing. And there were conversations with people around their choice of treatment. And if they knew their diagnosis and knew their stage of disease, they could have an informed discussion about whether to go with interferon or to wait. And for a long period of that time frame, while we knew there were new drugs coming, them arriving in 2014 as the definitive product, if you'd asked most hepatologists in 2013 whether that was going to happen, they would have happily told you it would be 2020 before the drugs were here. And there was a very accelerated phase of drug development that is unique at the speed at which these drugs arrived for widespread use. And so when people are thinking about treatment decisions, it's putting it in that context. We knew we had a fatal condition that was curable with interferon, albeit with significant side effects that we'll talk about in a while's time, but it was changing the natural history of the disease, and that we couldn't predict the arrival of the DAA therapies as quickly as they came.
Just one observation, probably not a question, but simply because I know it's a matter of some importance to many who are in the room or maybe listening. You talked about, from the clinician's point of view, the speed of introduction of these drugs. We know from other material that the inquiry has, and indeed has disclosed in the course of the week, from representatives of the National Health Service in the 4 jurisdictions of the United Kingdom, that following NICE recommendations and assessment, the drugs were not made immediately universally available to all of those with hepatitis C. I'm not going to ask you particularly to comment upon that because that's a matter of fact and policy decisions for which you're not responsible. But we do have statements from NHS England and from others that will be published either towards the end of this week or next week, which address those issues. Because for many, the speed that scientists may have observed in terms of drug development was not mapped for them as individuals when treatments were not made available to them.
And I think it is worth just probably spending a moment on it, because there was a very big issue about the cost of these drugs. And there was, I mean, we knew that the drugs were good, and we knew that we wanted to treat everybody, and there was a major impact potentially on the budget. And so the way it was handled in different home nations is different.
Yes.
And I think in particular in England, there was a different system which caused quite a lot of controversy. The way it was handled was the patients, the individual centres were told how many patients they could treat in a year, and it was up for them to prioritise which patients were treated. There was no guidance as to how you should prioritise, and I think there's very different experiences of how that worked in different centres and what criteria were used to prioritise patients initially. And you know, the experience at one centre was different from another, but there were very clear choices having to be made. And we're really talking about a recent period here, so we're really talking about 2015, 16, 17. Fortunately, I think we're now through that, and that really everybody should be able to get treatment quickly if they need it. But there was a period where there was a lot of there was discrepancy between practice in different places, which I think would differentially affected people with different routes of transmission in different places.
Could I just say as well about the impact on viral hepatitis in patients who have had transplants of these new treatments?
Yes.
Because what we've talked about is just general liver cirrhosis and transplant, but in years gone by, before there was effective treatment for either hepatitis B and C, if a patient had a transplant but yet the virus was still present in the blood, then it would affect the new liver as well, and would often have a faster course of progressive liver disease after a transplant, and that had a negative impact on the outcome after transplants for those patients. But now that there is effective treatment for both hepatitis B and C, we very rarely see any problem like that, and it's really transformed the outcomes for transplant patients.
One of my interests is therapeutics, and I sit on the local drug and therapeutics committee, and we look at new drugs coming in onto the market in a wide scope of areas, no less including these types of drugs becoming available. And obviously these were national decisions, but a local area, I would say that the speed for which this has got to this point, which from a patient's perspective is too long in the bigger scheme of the graph set out here. It's good that we've got through those pinch points so quickly in that time, but that was still too long for some. But for other diseases and in bigger scopes, for example, in rare cancers, for example, trying to get these drugs progressed as quickly as they need to be for everybody. Scottish Government and the SMC have done a huge amount of work in the past kind of 3 to 5 years to try and improve access to drugs as quickly as they need to be there. And it takes a lot to get these drugs available as widely as they could be, because you have to work out who pays for them, and that shouldn't be a limit from a patient's perspective, but certainly in a system where you don't have that money that needs to be paid to the companies to pay for the medicines, it's quite hard to make sure that that gets done. Still, it's too long, but the government are aware, and they do. There has been, in the time that I've seen medicines progressing to try and get onto market, the way and the structure for which drugs such as these are approved has dramatically changed to try and make that as quick as can for this and for many other conditions. It doesn't justify the delays that there were there, but things have changed, I think, as a result of medicine such as this, where the transformation and the access needed to improve and needed to be responsive to the clinical situation.
Could we turn to the next page, please, Henry? And we're going to look at a table that you've produced. If we look at the bottom half of the page, please, which talks us through adverse events associated with interferon and its associated toxicity. Before we look at any of the detail of it, can I just ask you about the heading on the right-hand side, frequency not known? Do I understand that to mean you're not suggesting that there isn't an association, but there simply isn't any available data to say any more about it?
That's correct, yeah.
And then we can see a number of conditions here set out. You've identified them on the left-hand column by reference to body system. So under the heading infections and infestations, we can see described as a common adverse event, a range of infections, bronchitis, respiratory infections, herpes, viral and bacterial infections and the like. And then uncommon and rare, but still an association, pneumonia, skin infection, endocarditis, otitis externa, and then a frequency not known, but an accepted association, sepsis.
That's correct. And just to give the context to this, I think we were asked directly about adverse events of interferon, and it was difficult to know how to synthesize that. And so what this draws on is what is provided with one of the products for interferon, the package insert for interferon. So this is from the manufacturer of this particular interferon, how they classify what is known about interferon. And we felt that as a starting point, that was probably as good as any that we could deal with. Now, I just want to emphasise that just because something isn't on this list doesn't mean it's not associated with interferon. And similarly, sometimes things are reported that are not necessarily due to the drug but happen at the same time, although that's less common. But I think that's a starting point. I think this is helpful. And for those who don't have the document, I think what we're looking at is a quarter of a very large table of things. So the coding on the left-hand side is from the manufacturers and classification. But as you say, even in that first line, some very common side effects which are important, infections and inflammation.
And these are based on a study population, I think, aren't they? So these will be based on people who were investigated and given the treatment in a study population which might not be representative of a wider normal population who have other comorbidities.
So I'm not going to deal with every single entry in it, but I'm just going to pick out a few that may resonate particularly with some of the evidence that we've read and heard from individuals. Identified there on the left-hand column, blood and lymphatic system disorders, and you've identified, again, a number of common, or some common, rare, very rare, and frequency not known, but associated manifestations of that.
And one that's worth pulling out there is thrombocytopenia, which means low platelet counts. For those platelets are one of the parts of the blood system which helps blood to clot, and is often low in patients with advanced liver disease and cirrhosis. So that's an important issue. If you're having interferon in the setting of advanced liver disease, then your platelet count may drop and the tendency to bleeding may increase, and so that's an important side effect.
And then we see immune system disorders, sarcoidosis, thyroiditis, and then anaphylaxis, SLE, rheumatoid arthritis, and others. And again, those resonate with the evidence that we've heard. Endocrine disorders, metabolism and nutrition disorders, And then I just wanted to pick up psychiatric disorders because we've heard a significant amount of evidence in relation to that. So this says very common, and we look at the top, that's over 1 in 10. Depression, anxiety, insomnia. Common, aggression, mood alteration, emotional disorders, nervousness, libido decreased. Uncommon, but still recognised, suicidal ideation, hallucinations. Then we see suicide, psychotic disorder, mania, bipolar disorders, homicidal ideation. So a very, very significant range of very severe psychiatric conditions.
Absolutely, and very well recognised and accepted that that is the case. And obviously that was always one of the difficult conversations to be having with patients in terms of the pros and cons of embarking on therapy like this. And I think probably it's fair to say that the most common reason that patients stopped treatment whilst having started it was related to the neuropsychiatric complications of interferon. And we've heard about the direct consequence to patients, but also the indirect consequence of that to people around them.
And picking up on what you say about conversations and difficult conversations with patients, not necessarily asking you to comment upon this, but a common theme in the evidence that the inquiry has received has been those conversations not taking place or not taking place in any kind of depth. So mild flu-like symptoms was a phrase that was used in the descriptions given by a number of patients. Now, what was known about side effects of interferon may have changed over the years, and that may be a matter of fact for the inquiry to investigate, but it's important to note the conversations you very properly say you would expect to take place may not have taken place.
Yeah, and you're right to highlight how difficult it is in retrospect to know what was appropriate conversation at what point. But certainly in recent years when we were using interferon, then discussions around neuropsychiatric side effects would be a common part. And patients may have had pre-existing conditions related to hepatitis C as well, so that would often be part of the management before starting interferon. John, do you want to?
Having been around this field for slightly longer than some of my colleagues, as they pointed out to me at lunchtime, so the problems that interferon wasn't a new drug when we were using it in hepatitis C. It had been used in chemotherapy for a decade or so before we started to use it, so we were aware of the problems. When we first started using it, we were admitting patients to hospital because of the fear of the psychiatric side effects, so we were aware of it and we had those conversations. We became more confident with treating it. We would sometimes use antidepressants and start them at the beginning of therapy, and it was very much a two-way conversation about the patients and the discussion. So I think those discussions, certainly they were in the guidelines to be had. They may have changed over the time from the early 90s through into the noughties in terms of how confident we were that all of those conversations were being had by everybody and appropriately. And I can't guarantee that everything was being done, but it was aware at that time and the conversation should have been had, and it should have been that conversation and practice between you have advancing liver disease, we have a treatment that works, but it comes with these risks and problems. And certainly the ones that are listed here at the 1 in 100 rate would be part of the list that we discussed with the patient.
If we go to the next page, please, Henry. Again, we'll just pick out some of ones that may be particularly significant for individuals. So if we could highlight the first half of the page, for those of us with less than brilliant eyesight. Nervous system disorders, so we see a range of potential complications there: headache, dizziness, impaired concentration, memory impairment, weakness, tremors, nightmares, somnolence, and then peripheral neuropathy, something we've heard from a number of statements, rare complications, coma, convulsions, facial palsy. Again, any particular observations that you have about those?
Well, I suppose just two points to come back to, which is first of all the overlap in this with what we've heard already about what the virus can do, and the challenge that creates for patient and carer alike, but also the difference in sometimes in reversibility. So coming off treatment would often result in an improvement in many of these symptoms, but not all of them. And for example, peripheral neuropathy may be longer lasting after treatment. So I think it just illustrates both those kind of general issues.
Then we have a number of eye disorders, ear and labyrinth disorders, cardiac disorders, So in the common column, tachycardia, edema, peripheral palpitations, and then a number of rarer but significant complications. And then if we could have the bottom half of the page, please, Henry. Vascular disorders, you see there including hypertension, cerebral hemorrhage, respiratory, thoracic and mediastinal disorders, again, a number of different complications there. Can I particularly ask you in the rare column there, we have reference to interstitial pneumonitis, including fatal outcome and pulmonary embolism. So very, very significant side effects, consequences, adverse events, even if relatively rare ones.
So I think it's important to how this data is drawn together. So every report of a complication of interferon is added to the SMPC. Yeah. That's the way it's written. So there will be cofactors in this. So if you have someone with chronic obstructive pulmonary disease, for instance, who then develops an interstitial pneumonitis on top, if the interstitial pneumonitis had occurred in someone with normal lung function, it wouldn't have been a significant problem. The interferon would have been stopped and it would have stabilised. Clearly, someone with significant comorbidity, then there were a substantial number of patients that were not suitable for interferon therapy because of the risks of these drugs. So it was a question of balancing those risks between them. And so they were, it's not, so it's putting it into that context.
I think the other point worth saying is that, if you're looking after a patient who's on interferon treatment and they're describing a symptom that's not on the list, you can report that and add it. And it's obviously where that is a very severe thing and the patient's very sick as a consequence of it, that's more likely to get reported. So I think you tend to see in the rare things more severe things.
Yes.
And that's kind of reflects what gets collected.
And then if I could just pick up skin and subcutaneous tissue disorders, because again, we've heard a lot of evidence about that. You've listed there, or there is listed there, a range of very common and common symptoms, including rash, sweating, skin disorders, photosensitivity, night sweats, again, experiences that we've heard a number of witnesses describe. If we could then go just over the page, please, Henry, to the last part of it. So we have musculoskeletal and connective tissue disorders, including myalgia and arthralgia, back pain, arthritis, muscle weakness, bone pain, neck pain, musculoskeletal pain, muscle cramps. And I'm just looking here currently at the very common and common disorders. Common complication in terms of reproductive system impotence. And then general disorders, and then administration site conditions. And if you could just explain what administration site conditions means.
So this usually relates to injection sites and infection in particular that can occur there.
But here again, in the very common and common columns, we have pyrexia, rigors, pain, asthenia, fatigue, injection site reaction, irritability, chest pain, influenza-like illness, malaise, lethargy, hot flushes, and thirst. And again, descriptions that we've heard from a number of individuals who underwent this treatment. Can I then just turn to ribavirin, please? And we can take this more shortly, but your report sets out, again, a range of very common side effects. And perhaps you could, for the benefit of those who don't have the report, just summarise some of the key ones for us.
So we felt it was important to try and be as comprehensive as we could be about interferon side effects, and I think in response to some of the supplementals we've been through as well, specific questions about things that we are in the report. Ribavirin is always, in the context of hepatitis C treatment, is always used with interferon. Yeah. And so we haven't gone into detail about all the side effects of ribavirin because many of them overlap with interferon because they're always given together. It's hard to know which is causing a problem. But there are some key side effects that are related to ribavirin, and most important of those, or most common of those, is anemia, where red blood cells are broken down by taking the ribavirin. But the reason it was still used, and still is used, although less so than it used to be, is because in some settings it does improve the cure rate by taking it. And so that was the trade-off that was given. But clearly there is, as we've said here, a long list of other relatively common side effects, including depression, insomnia, headache, altered concentration, and many of the things that we've already discussed. So in contrast to some of the interferon side effects, most of the side effects from ribavirin are reversible. In particular, the anemia tends to recover quite quickly, but nonetheless can be quite significant during treatment, leaving patients feeling very weak and difficult to do daily activities.
You've then set out in your report in some detail a description of the first generation of direct-acting antivirals between 2011 and 2014. I'm not going to ask you to go through those with the same level of detail, although in some respects a significant improvement on interferon and ribavirin, a number of them did still carry with them significant side effects.
That's correct, and I think the important thing to remember is that these were being added in on top of interferon and ribavirin, so you were already dealing with quite toxic combinations of treatment. And the only reason they were used was because of the improvement in cure rates that could be achieved. But some in particular, telaprevir, and some of the issues of itching and skin rash, and quite severe skin rashes were quite a big issue. And it's a sort of reflection on those drugs that actually none of them are used now, even though they're only 7 or 8 years old, those 3 drugs in particular.
Yes, and it's not long ago, 2018, that those were withdrawn from the market. And then, finally, before we break, sir, I'm watching the time, interferon-free treatment. So the current era, again, you've listed the various combinations in the report, so I don't need to ask you to go through each of them, and those listening who've had the treatments will know them better than anyone. 2 features I wanted to just ask you about: the duration of the treatments, which seems to be much, much shorter than the duration of interferon, and then the extent of side effects.
Yeah, so I think it's really the 3 features. So it's those 2 that you mentioned, in addition to the higher cure rates that can be achieved, with durations of therapy which are now 2 to 3 months, really, compared to what would have been at least 6 months of treatment with interferon, and side effect rates which really are very substantially lower. And I know from conversations that there's still suspicion about these drugs for some people, but really the adverse events we see with these drugs are minimal, and I think I can't even think of somebody who's had a problem that I've treated. So that all of those factors have transformed the discussion you can have with patients, what patients can be offered and expect from their therapy now. And we mentioned about how availability of those treatments is different across the UK, but we are in a position, I think, broadly speaking now, that anyone who's got infection and needs treatment can get it relatively quickly. There may be local issues about which treatment they get, but that is now accessible, and it's really only in the last year that we've been able to treat everybody we want to treat.
And I think by quickly, the last one that I diagnosed, from a GP's perspective, from seeing a slight rise in their blood tests to then getting confirmation of the diagnosis to them starting treatment was in the order of weeks. And to completing treatment, at the 3-month point, they'd gone from the point of not knowing they had it to completion of treatment in a very, very quick time scale, which is even 3 or 5 years ago just would we be being testing them. That can be discussed but very, very different perspective now for where we've got to.
So I'm moving on to a slightly different topic, so I think that's probably a convenient point to stop.
Well, I think so too.
Just to say, for the benefit of those sitting behind me, as with yesterday, if there are questions arising out of the evidence of the panel that core participants want to suggest, I've tried to incorporate a number of them as we go, but if there are still further questions, if they let me know over the course of the next half hour.
Thank you. 3:30. Yes.
Just following on from the material we looked at about the side effects or adverse events associated with interferon, we also asked you to look at a number of other conditions, complications, or potential consequences that were listed in annexes to the letter of instruction, and ask you to say whether there was a known association or a suspected association with hepatitis B or C. You've dealt with that in your report, so I'm not going to ask you to go through it in the same way as we've done with interferon. But I am just going to put up on screen those parts of your report so that those who want to have that information will know where to find it in the report. So if we could perhaps just have, first of all, Henry, page 49, again using the report's internal pagination. So if we just look at the fourth paragraph down, which refers to Annex 2, in respect of Annex 2. If you could just highlight that, please. So just, again, for the benefit of those listening either here or elsewhere, your report is in full available on the inquiry's website, as are the questions and the annexes, and they are all easily accessible there. And you've identified here that most of the conditions that we asked you about were reported for interferon, and you've summarised a number of them there. And then you've picked out there that a vascular necrosis is not listed, but there's some limited literature associated with HCV and or interferon use. And then, Henry, if we could just go on, please, to page 58. You can see the inquiry asked you about other health conditions or complications that may have been caused or contributed to either by the hepatitis infection or the treatment. And you've dealt with those again in the report. So if we look at the bottom third of the page, please, Henry, you've identified there under the heading Main Extrahepatic Manifestations of Hepatitis C virus infection, classified according to the strength of the association. And then you've said adapted from Cooke et al. And could you just explain what the classification is?
So this is a published paper who they had reviewed the available literature and grouped the level of evidence around the literature and put it into these categories. So I think it's important to realise the way evidence is collected in medicine, and there is evidence of effect where you start off by having an association where you notice two things occur more commonly than you would expect. You then find a plausible biological mechanism that links them together, and then you prove in a trial that if you do one, the other thing happens, and that proves causality. For almost all of the manifestations, we don't have that level of evidence. We have evidence of association. But because of the way that evidence of association is captured, if there isn't evidence, it doesn't mean that it doesn't happen. That means there's an absence of evidence, and we just don't know because the report hasn't been gathered or that there is not that level of data. So for syndromes and things that are very specific and very characteristic, it's easier to report those, and they're more easily noticed in the literature. For constellations of symptoms that are less cohesive and less tied together, it's harder for those to be reported in the literature. It's therefore harder for people to notice the associations and to start to explore them in things. So in this area, we've tried to plot out those levels of what we have seen in the literature and what's known. If they're not on the list, it doesn't mean that that it doesn't happen, but we don't have evidence that it's happening.
And so anyone who's looking at this published report will see listed there conditions with significant prevalence and consistent pathogenetic data. And we've got two conditions listed there. In particular, I draw attention to B-cell non-Hodgkin lymphoma because we've heard evidence in relation to that. You've then listed a number of conditions where it's recognised that there is a higher prevalence in HCV-infected populations compared to controls. I won't go through them, but we can see a number listed there. If we go over the page, please, Henry, we see a range of other conditions listed there. We then have a category of conditions with possible association with hepatitis C, and we see 3 conditions listed there. And then conditions with anecdotal reports of association. And perhaps you could just explain what's meant by anecdotal reports.
So anecdotal reports are where people have noticed that these two conditions occur together more commonly, but they've got a small number of cases and they have reported those in the literature. In some occasions, that means there are another 1 or 2 other case reports of other people that have noticed the two things together, but there's not a systematic review of all the evidence in a population to try and work out what would happen. That would be the next stage of those investigations.
And then if we just look down the rest of the page, please, Henry, we can see you've then gone on to discuss a range of particular types of complication. We've dealt with liver disease and cirrhosis. We see there a description in relation to vascular disease, including vascular dementia, and I'm just simply drawing attention to that because I know that's a point that a number of individuals have raised. And then if we go to the next page, we see cancer. We've addressed, obviously, liver cancer, but other increased risks of other cancers you've addressed there in the report, and that's on page 60 of the report. You've addressed a range of musculoskeletal problems, and then if we continue down, a range of autoimmune and multi-system disorders, explaining that HCV infection causes immune cell dysfunction, and you've identified there a number of syndromes with which that's associated. Mental health, and you've talked there about the association, the strong association between HCV infection and mental health conditions. And then, and thank you, Henry, over the page, respiratory conditions, and then you've identified a handful of conditions in which there is no evidence of association. So for reasons of time, and because you've answered the questions in the report, I'm not going to ask you to go through each of them now, but the report is there and provides that information to those who would like to see it. Can I then, before we look at the next part of your report, just ask you this. Many individuals have reported that following the cessation of treatment with interferon or interferon with ribavirin, pegylated interferon, the symptoms that they experienced, in particular symptoms such as brain fog, depression, fatigue, did not go away. And many of them report that they have endured those for years. Can I ask for any observations that you may have on that?
So if we look at the trials overall, those symptoms get less common after successful treatment. And so a proportion of the people affected by them, it's clearly caused by hepatitis C. For the other residual symptoms that are left after cure, it's a question of whether there is something else going on that's causing those symptoms, or alternatively that the hepatitis C had established some pattern of damage within the brain or the behaviours associated with it that didn't change after treatment. And so we know that the treatment reduces the incidence of those symptoms substantially. A proportion of patients, they don't resolve, and it's either because of some permanent damage the hep C has left behind in the brain in terms of an adaptation, or there was something else going on.
I wanted to ask you to deal with the next part of the report, which was looking at the significance of co-infection. I'm not going to ask you about the section of the report that asks about hepatitis and the relationship between hepatitis and haemophilia, von Willebrand disease and thalassemia. The reason for that is that there is an expert coming on Friday who will better be able to answer those questions. That's what you've told me, at least. That's not my subjective judgment on you.
No, we're very grateful.
So can I ask you to start with co-infection with HIV and perhaps ask you, Professor Cooke, to address that?
Yeah, certainly, and I think it will come up again tomorrow, I'm sure. But it's obviously relatively common to see co-infection of both hepatitis B and HIV and hepatitis C and HIV through shared transmission routes. And I think in both cases there are clear interactions where the presence of HIV affects what happens to the hepatitis B at different stages. So and hepatitis C. So just to very briefly go through then. Individuals with HIV are more likely to have chronic infection once they've been infected with hepatitis B. When chronic infection is established, it's more likely to have a higher replicating amount of hepatitis B, and that in turn can be related to a more rapid progression of liver disease as a consequence, with more rapid progression to cirrhosis. And indeed, in the HIV cohorts across Europe and the UK in recent years, until relatively recently, liver disease was growing as a relatively important cause of death amongst patients with HIV. And it's also worth saying that that has changed quite a lot with advances in treatment, and I mentioned earlier one or two treatments which treat both HIV and hepatitis B, and with effective treatment a lot of that can be reduced, but for many years that wasn't possible, and that was a real problem. And similarly, with hepatitis C and HIV, there's a similar issue where if your immune response is weaker, then you're more likely to develop a chronic infection after exposure. Again, you can see a more rapid progression of that condition. The viral load in hepatitis C is a little bit different, but nonetheless, the disease can progress more quickly. You're more likely to get advanced fibrosis, cirrhosis. And on top of that, in the setting of hepatitis C, then we talked about interferon stimulating the host immune system. If you've got a weakened host immune system because of HIV, that interferon is less likely to be effective. And so some of the guidelines from European guidelines, for example, recommended 72 weeks of interferon for patients with HIV, so really very substantial durations of therapy, and again with lower success rates as well as a trade-off. But equally again, the newer treatments that directly target the virus seem to be as effective for patients with HIV as without, and have been able to clear the virus for those patients. So there's a number of different interactions. I think in the report, those are the ones we've highlighted. I think it's just worth emphasising that, of course, that the psychosocial element of both viruses we heard a lot about, but it can be additive, and there are different effects for an individual patient as to how they perceive those viruses and the stigma that they might attach to different viruses, even though they have both. And I think the other thing that we didn't put in the report that's worth mentioning is that some of the HIV medications, certainly even some of the ones we still use now, can also have neuropsychiatric side effects. So one drug in particular, efavirenz, which we've used very widely for HIV, is associated with depression. And that can be an additional factor of complication, particularly for patients with hepatitis C who may have further problems. So there's a range of important interactions.
And is this also right that for some of those who were co-infected with HCV and HIV, they would not have been able to receive treatment with interferon?
So there are always a group of patients where that was difficult, but tended to relate to advanced liver disease. I think it's more about the discussion about the risks and benefits. I think you're having a discussion about a much longer course of treatment with a lower chance of success. So there may have been a choice that would be more likely to be made in terms of waiting to use that treatment for HIV patients. Do you want to add to that, John?
I would agree. I think it was a different discussion and there were also more risks associated with hepatitis C interferon-based therapies in someone who was co-infected with HIV, with a much reduced chance of benefit at that stage. And so it was this play-off between how severe the liver disease became a much more significant discussion during that development.
And you've said in your report, advanced HIV is associated with a worse outcome for both HBV and HCV.
Yeah, so by advanced HIV, we'll talk about this more tomorrow, but we mean people with a weakened immune system. The CD4 cell count that we tend to talk about being low is a marker that you'll respond less well to treatments like interferon.
And then can I ask you next about co-infection with other hepatic viruses?
Yes, so I think in the report we've touched on quite a lot of these things already. I think one of we've mentioned hepatitis G already, and we've talked about hepatitis D. I think one of the things that will be of concern and interest to some people is the idea of triple infection, and clearly there are a number of patients, not in considerable numbers, who have been infected with HIV, hepatitis B and hepatitis C, and that has different implications that are a little bit complicated, so that those viruses can have an interaction in a patient as to what that means, and often one virus will dominate but may come back if the other virus is treated, and that's an issue that we still deal with a little bit in practice. And again, hepatitis D can also be an additional factor. So for a small number of patients, there is an additional complication of multiple co-infection, which is a challenge.
And treatment decisions, obviously, for the reasons you've given, may become much more complicated for patients who are experiencing that.
And there's an issue which is still an issue, which is about the issue of hepatitis B, which can be less obvious before you treat hepatitis C and then can flare afterwards. And that's something we've recognised more in recent years with some of the treatments, and that we can take measures to prevent, but it does require a certain sort of more complicated management approach.
Well, I think it's fair to say that things have become much easier with the arrival of the DAAs. It's made the management of HIV and hepatitis C and hepatitis B much more straightforward, and we've now spent the last 4 years learning our way around those, and I think that it's become clearer and easier from the patient's perspective.
Can I move on to section 15.18 of your report, pages 53 to 54 for those who have the report? The question you were asked was about whether hepatitis can be cured or whether it remains dormant and is only undetectable. And I think you've addressed that in relation to hepatitis B already. Can I just ask you to say a little more about hepatitis C? One of the particular questions that some core participants have asked is whether it's right to talk about cure or simply suppression of hepatitis C.
Yeah, I think this is really important, and I think it's worth going into a bit of detail. I think it is, as we've said a number of times, it is a very different approach to treatment where we are trying to get rid of the virus from the body, although that doesn't necessarily mean there can't be traces of that virus found, which sometimes can confuse things. We've acknowledged, I think, in the report that there's been a bit of controversy around cure, and part of this came because there was a very high-profile report that came out about 2 or 3 years ago from the Cochrane Group, a very well-respected group who reviewed new treatments for hepatitis C and got a lot of publicity when they published a report saying that there was no evidence of cure. And what that meant was not that the virus didn't go away, but was that the clinical consequences of that viral infection didn't necessarily go away completely. And the reason for that was that actually it was based on studies that hadn't really looked at patients for a very long time after they'd finished treatment. And we know just as the complications are slow to come on, the benefits of treatment are relatively slow to come on in terms of preventing advanced fibrosis and liver cancer. So I think it is right to talk about cure. It's cure of the virus, but it's not necessarily cure of everything. And I think that's an important distinction that I know for many patients is important, both in terms of what we've heard about the neurocognitive side effects and the liver disease as well. So we do talk about cure, and we use these markers that we've talked about as a sort of surrogate for that long-term cure in terms of the presence of virus after treatment. And as we've already mentioned, then it is also possible to get reinfected. So we have to be careful if we see a patient with viremia to work out whether this is actually an infection that's come back or a new infection. And with the newer tests that we can do with the virus, we can be more confident about that. And often we do find that patients become reinfected rather than sort of relapsing late on. And I think that's sort of taken away some of the anxieties that people had about relapsing infection. But I think I'm very comfortable with the idea that, and I think we all are, but I mean, there is controversy outside the field in a little bit, that we can talk about cure from this perspective.
Professor Dillon.
I think we should be unequivocal that there is a cure. I think the Cochrane report, for those people that want to think about it in more detail, what the Cochrane report were demanding was that we did trials until death and that we didn't treat people. And that, I think, is unacceptable. And I think the Cochrane report was rightly condemned by the whole community, and has, most of the committee that produced it have retracted themselves from it because of that purpose. We have shown previously that SVR 24 or 12 is a very, very good surrogate for cure in the long term, and we therefore don't need to not treat people for decades to show that the people that treated were benefited. Now, cure of the virus means that if you've been detected early and most of the scarring hasn't happened, then you can walk away from the consequences of hepatitis C, thankfully. If you're treated later, then there is still some associated risk, which we will get on to discussing how that's managed and looked after. But even in those patients, the risk falls substantially once you're cured of the virus.
Just dealing with that latter point, in your report you say there's a large body of evidence that achieving SVR 12 or 24 is associated in the longer term with significant reductions in all-cause mortality, liver cancer and liver failure. However, these risks remain higher than in patients never infected with HCV. And again, you've given more detail about that in your report. So it goes back to an answer I think you gave before lunch. Successful treatment may reduce the risk of what would otherwise have been the natural progression of the liver damage, but it doesn't reduce it to the level that it would be if you had never had hepatitis C.
So the evidence base at the moment, because we are, if you like, the first generation of people who were cured of hepatitis C by the DAAs, were of advanced disease, but we cured them 4 or 5 years ago, so we're still following them up. What we know is that over those 4 or 5 years in Scotland, their risk of liver failure has fallen dramatically. Their risk of liver cancer has fallen, but not as quickly. But we will carry on monitoring that, so these are the patients who are left with significant scarring and cirrhosis. And in people who have minimal fibrosis or no fibrosis when they're cured, their risks go back to normal very quickly, and they have no risk of progression from what we can tell. For those that have cirrhosis, which if you look at the whole population, there is a group of people who will be carrying that scarring with them. They still have some risk, but the risk is much reduced.
And you've, I think, sought to quantify to the extent that you're able to on the existing material those risks on page 56 of your report. You say after cure, a person with cirrhosis would expect some regeneration of the liver, which would improve health and symptoms of liver failure, but they may be left with residual symptoms and signs of liver failure. You say this will be a small proportion of those with cirrhosis, and those people may require liver transplantation. You say the majority of those with cirrhosis who've not yet reached the stage of liver failure are likely to get some improvement in liver function after SVR, but still have a long-term risk of developing HCC.
Yes, and I think that's the estimate at the moment. It's certainly fallen over the 3 or 4 years that we've been watching it, and we've shown that we've just published that data for Scotland at the national level, so the risk falls. How much more the risk will continue to fall over the coming years, we'll just have to monitor it, but I think we will continue to monitor patients who are at risk of that, and it's patients with significant scarring at the time that they're cured. And I think for the people who have cirrhosis but weren't in liver failure, there appears to be no risk of progression to cirrhosis and liver failure unless there are other cofactors such as the metabolic obesity and alcohol playing in as well.
And I think it's worth emphasising that we think in general that how you achieve that cure, it doesn't affect the benefit of it. So if you achieved it with interferon or interferon ribavirin or the newer drugs, then that you still have that benefit of cure of similar magnitude. And I think one of the questions that we've just touched on that it remains unclear as to how we help patients who've been cured of the virus who still have scarring or cirrhosis to understand the risk going forward. And those are studies that are currently running in the UK trying to understand that risk.
Picking up on that point and what patients would be entitled to expect as a matter of basic good practice in terms of follow-up, we have had evidence that suggests a patchy and variable position for specific individuals, some who have not had, despite having liver scarring, any form of follow-up. So I wondered if you could just explain to us what you say that patients should be entitled to as a matter of basic good practice.
So in terms of people who have established cirrhosis, and I'd like to follow up with a point about how you make that diagnosis of cirrhosis, they should be followed up regularly for hepatoma screening. They should be followed up to look for esophageal varices, and therapy should be arranged if they have varices to reduce the risk of bleeding. That clearly is with patient choice, and that the pros and cons of follow-up and screening should be discussed with the person involved, and they should make the decision as to whether they wish to go through that screening, but that's what should be offered. In terms of the diagnosis of cirrhosis, historically we made the diagnosis of cirrhosis with liver biopsy, which we now don't do because it's a risky and unpleasant procedure. And we use other techniques to estimate the amount of scarring in the liver, either blood tests or imaging-based techniques. With these imaging-based techniques, they are different in the way they measure the scarring in the liver. And so if we have uncertainty, we will trigger screening lower levels of scarring on the liver. So patients who may not be fully cirrhotic but carry a lot of scarring, we will offer them screening as well so that the system fails safe in that way. I think it's important to remember Dr. Marshall's pictures about the progression of liver disease, and there are lots of scars on those pictures that she showed. And so the way that things may have been explained to people along the line in terms of scarring and severe scarring and cirrhosis needs to be clarified for people as to what their risk actually is. And we know that quite a lot of those early scars disappear out of the liver biopsy after treatment as well. And so there needs to be a discussion as to when you were told you had scarring on your liver, how bad the scarring was, and whether you still need follow-up for it. But I think that there has been some uncertainty about what to do, and clearly some people, who's been treating, etc., and who would follow people up. So hepatologists, for instance, will spend their entire lives following up people who are have some scarring on their liver, whereas people from an infectious diseases background might think the virus is done, it's over to the liver doctors to sort out, so there may be some of that going on. There should be clear guidelines for every hepatitis C treatment service across the UK as to who needs follow-up and who's going to do that follow-up.
You say there should be. Are there?
There are guidelines, and it clearly states what they should do for both British Association for the Study of the Liver and for EASL, and which we all follow. And so that those guidelines are there, and practice should be instituted appropriately.
So if I can ask you about three different categories of patient then. The first category, the patient who has achieved SVR, whether it's SVR12, SVR24, and there is no evidence of liver scarring. My understanding from your report is you would expect they would be discharged from care without any follow-up.
To their GP.
I'm sorry?
To their GP.
Yeah.
Yes.
Although that's not universal, but I think that would be what we would say as a group.
What, if anything, would you expect their GP to be doing in those circumstances?
It depends on the individual. So it's a discussion with the individual about what, obviously the causes of in the first place and the ongoing lifestyle issues need to be individualised, and you need to cater for that for the individual. I think obviously we already discussed that the lifetime risk is not going to end up being zero, and I don't think the evidence as yet exists as to how exactly, if you were going to monitor these patients lifelong, would you look at that? John,
So I think that for the patient who has no scarring, it is fairly clear there is no risk in the long term, no risk compared to the general population.
But I guess I was hinting at what the cause of Hep C was in the first place. It's a
Yes.
reinfection. So I think that's what I'm trying to.
If we're confining this to the infected blood cohort,
Yeah.
then which is the purpose of this inquiry, then there wouldn't be clearly if there are other multimorbidities in a person's life, we would deal with those and move on from that point of view. For someone who has acquired hepatitis C through an infected blood route and they're cured, there would be no ongoing transmission risk. There would be no ongoing risk to them as an individual if they have no fibrosis or scarring, and they could live their life as a normal person. And we'd be keen to get that, albeit that there would still be the haemophilia treatments, etc., that would be a part of their background life.
So we've got that category. At the other end of the spectrum, we have the category of the patient who has achieved SVR, but who has cirrhosis. Am I right in understanding that whether they have compensated or decompensated cirrhosis, they should be receiving follow-up monitoring? And
That's correct.
Yes, they should. Yeah.
and how frequent would you expect that to be in terms of scans and blood tests?
So the guidelines suggest 6 monthly ultrasounds and probably annual clinical review, be that with a nurse-led clinic or a consultant-led clinic or a GP with a specialist interest. So someone with a special interest within the management of chronic liver disease should be reviewing the patient annually.
And that should be for the rest of their life?
Yes, or until they grow tired and make the choice that they don't wish us to go forward with it.
So the more difficult category, maybe those who don't fall into either end of that spectrum, the patient who has scarring, fibrosis, but not reached the stage of cirrhosis. And it sounded from what you were saying as though those may be matters where the guidelines are less clear and there may be questions of clinical judgment, or have I misunderstood?
So there are issues of clinical judgment. The measure, because we're not liver biopsying anymore, the measures of fibrosis are a little grey in those areas. And so if we would divide those patients into those with quite a lot of scarring and they might be on the verge of cirrhosis, and we would discuss that with them and offer them follow-up as if they had cirrhosis. And most people opt for that option when given it. or that they have very little scar, they have a little bit of scarring, it's not very much, but they do need to be aware of keeping their weight down and their alcohol intake for the future, as the Hep C related scarring will never cause them any harm, but they are, if you like, one step up towards cirrhosis, and if they add to that step, they could progress. So it would be, as Scott was alluding to, lifestyle advice about reducing the risks of those progressions.
And what about something that's neither very light scarring nor on the verge of cirrhosis?
So I think that we would draw the line in, split them in two.
Okay.
If you want to stick one in the middle and there was significant doubt, perhaps because we had two fibrosis markers that disagreed with each other, there will be a discussion with the patient about how they wanted to err on the cause and whether they wanted 6 monthly ultrasounds and endoscopic examination, or whether they were prepared to not have that because it was of limited benefit, and that would be a discussion.
I think shared decision making really is that underpins that. Though, because we're living in such uncertainty, these drugs we're hopeful of the long-term outcomes, and we continue to monitor that. But where this grey area in the middle with that massive amount of uncertainty, shared decision making and explaining uncertainty, and then looking at the patient's core values and their priorities, and bringing that into it has got to be key at that stage. And in my experience, that's usually helps shape that plan.
And I think this is where it's important that empowering and educating primary care is an important part of this, because as many people will know, often people are travelling quite substantial distances for their liver care, and to go every 6 months when you're very well for a scan to quite some distance is difficult. And I think the closer that care can be delivered to a patient going forward, the better.
Picking up on what you've just said about shared decision-making and the importance of discussions between clinician and patient, I'm just going to ask to have up on the screen a section of the report. It's page 61 onwards, please, Henry. And again, I'm not going to go through this in detail, but it's to signpost where anyone who wishes to read the report will find it. If we look at the bottom half of the page, please, Henry. So you were asked the question about the advice and information you'd expect a patient to be given now about hepatitis. And you've set out a number of general considerations about the kind of discussion that should take place. In particular, you say that there must be a suitable environment with adequate time given for such an explanation. I know those of you who heard some of the psychosocial evidence yesterday will obviously understand the importance of these issues. Can I ask, and recognising as I do, you distinguish between what the GP might do and what might happen in secondary care, what do you mean by a suitable environment with adequate time given for explanation?
Should I start? So I think it depends on the context in which hepatitis C is being diagnosed. If it is in a context where it is expected and not unexpected, for instance in an addiction psychiatry setting or a needle exchange, for instance, then that's a very different discussion to a diagnosis that's made because of a blood transfusion that happened 25 years ago and you were in for an insurance medical and had an abnormal ALT discovered. And that would clearly be usually in a hospital environment because the patients will be able to access this, having had some preliminary information from their GP, and hopefully the GP would have had access to online information that they could pass to the patient. And hopefully that suitable environment would be with someone who was knowledgeable about the condition and knowledgeable about the treatment and how that treatment plan would be evolved. And I think that's moving forward quickly.
And if we turn on to the next page, we can see you flesh that out. You talk about giving the opportunity for a full discussion. You talk about the importance of effective shared decision-making, of listening to patient preferences, of ensuring the patient has the information they need to make an informed choice. You talk about an equal partnership between patient and clinician. And then you set out some of the kind of basic information you would expect the clinician to be providing to the patient.
Yeah, these were kind of set out as almost at a primary care level, some of the very core information that we fully appreciate. I've highlighted there, different learning and literacy issues need to be catered for, including the use of pictorial explanation and patient support and supporting patient self-recording as well. And we know when you're giving important diagnoses that patients will often not remember a lot of what you say, and so trying to facilitate that in any way you can, cognizant of the patient that's sitting in front of you, you must have due consideration to that. In particular, if it is an unexpected diagnosis, how are you going to help manage that in a GP appointment when they're going to be walking out the door soon afterwards? After the discussion, how can we make sure that we support that properly, and ensuring that I know that I'm referring, in my case, I'm referring to Professor Dillon's service. I know that from there on in, it's a bit of a snowball, it's a bit of a roller coaster, and so we're making sure that we're adequately preparing them for that process, and that they've got the supports around them that they need, and that they're being signposted to the right sort of information, and trying to give them some caveats and hints as to how to manage that process. But remembering that they remember very little of what you say, barring the diagnosis, which is an important thing to remember, which all GPs are trained in discussing, and hopefully manage to implement effectively.
And just to add a couple of things, I mean, I think you can see from looking at this that there's potentially a lot of information that would be needed to be shared. And I don't think we would want to suggest that necessarily all had to be done at one time. No. And that sometimes that's broken over serial conversations, and particularly in secondary care, I think we've heard a bit about the importance of specialist nursing, and often that conversation will be shared between a specialist and the nursing team, who may have more time allocated where that can be done, and different services have different levels of provision for that. I think that's quite important. I think the other thing to say is that it's quite hard to find a single recommended list of things that need to be told to people. So what we've included in the report is a couple of examples of local patient information sheets that have been developed for patients, and there's links in the report. And I think we felt that they were quite good examples of what could be done, rather than saying that was what needed to be done. But I think if someone wanted a starting point, that'd be quite a good place to look.
And you set out on page 63 some of the particular kinds of information that should be provided. The top half of the page deals with hepatitis B, the bottom half with hepatitis C. This, I think, would typically be in secondary care, as I understand the report. Or could it also be in primary care?
It depends if the question gets asked. I think I'm very mindful in these conversations that the patient is not going to remember a huge amount of what we discussed, bar the diagnosis, and I'm going to be wanting to offer that referral and early access to treatment. And so it's patient-led as well as to what they want to know and where they're at. So it's very individualised. The information is there and we can offer to discuss, but you've got to be led by where that conversation is going. The priority is to make sure that they're very clear that I have offered treatment and we have offered access to services, and to looking at their values and their beliefs and their priorities to see how we can to make those match, to distill down to what I suppose you would call optimal care, which takes the combination of our evidence and our guidelines and the patient's beliefs and their core values and their priorities, and we'll distill it down to what their priority is at that moment. And that's the same for the conversation that I might have, but is equally transferable to the conversations my colleagues might have in secondary care as well.
And I flagged that up because the evidence that we have heard, not from everybody, but from a number of individuals, describes experience of being given information or not being given information about, in particular, hepatitis C, which is not consistent with the model that you've set out here. So what you've set out is what you say should be done. Mm-hmm. I'm not going to take time on it now because you've dealt with it fully in your report, but you've dealt with issues about advice about conception if someone is infected with hepatitis B or C or is undergoing treatment, and implications for fertility in your report from pages 64 and also page 70. And I'm just, again, drawing attention to that because some individuals had raised questions about that. You were asked in the report just to comment upon the World Health Organization initiative. This is the initiative to eliminate hepatitis C, and also to set out what was being done in the United Kingdom towards that. Your report covers England, Scotland, and reference to Northern Ireland, but not Wales. And I wondered if that's simply because you didn't know the position, or whether do we infer from that that steps are not being taken in Wales?
So we looked for publicly available documents at the time we wrote this. My understanding is, and I haven't checked this, I was told this yesterday, that I understand there is a document now on the Welsh website about the plans afoot there. So there are clearly different levels of complexity and progress in different home nations, and I think the Scottish example is probably the best at the moment. But there are plans in all the home nations to make progress with elimination, in line with the WHO targets, which are really, they're quite aggressive. There's an ambition to try and substantially reduce mortality and transmission of hepatitis, viral hepatitis, both B and C, by 2030. And I think certainly the UK government, the English health system, I think, has stated a target of 2025 for elimination of hepatitis C. I think the Scots may have said 2024. Yeah. That may be coincidence.
But I think they came up with theirs after 2025.
Well, the Scots are going one better.
I think that might have happened. I think that was Professor Dillon's doing.
Certainly, steps towards elimination are advancing well. Within one region, within Scotland, we are likely to achieve elimination by the World Health Organization definitions this year, and Scotland is on track to achieve it by 2024. And it does require more effort and public awareness around hepatitis C, the fact it can be cured, and where it is in our populations, and how we have to bring people forward for diagnosis and cure.
I think there's a helpful concept of micro-elimination that's being used a bit, and that's where we look at particular risk groups and try and achieve up to 100% cure of everybody in that risk group. And clearly I think people with certain blood disorders fall into a risk group where that could be achievable in reasonably short time. And in HIV, we've got a national programme trying to achieve that, and we've made progress with probably fewer than 10% of patients left to be cured of hepatitis C. So there is real genuine and high ambition for elimination, particularly in some key risk groups.
One question that I've been asked to raise with you is the explanation, if any, for the length of time it took from the development of the hepatitis B vaccine and its use for at-risk groups to universal vaccination in the United Kingdom in 2017. And I think you were perhaps more than happy to answer that.
I've spent 20 years standing in European, African and Asian meetings being embarrassed by being apparently a country too poor to spend the money on hepatitis B vaccination. I think the fact that there hasn't been universal vaccination for hepatitis B in the UK has been a disgrace. I'm delighted it's now happened, but it's took 20 years, and I think it's poor practice.
And to the best of our understanding, that was based on what was perceived to be the cost benefit of doing that. And that calculation has changed. So,
what was put on the benefits side? That's obvious. What was the cost?
So simply the numbers of people that would need the vaccine on an annual basis, and even a relatively cheap and effective vaccine like hepatitis B, if you're vaccinating every infant, that's a significant cost to the health service that needs to be traded against other things that money could be spent on.
They believed that the number of people that would contract hepatitis B, need chronic treatment or die from it didn't justify the cost of vaccination.
And the cost of treating them for those conditions wouldn't justify the cost of vaccination? According
to their health economics.
I think penultimate topic arising out of your report I wanted to ask you about before I move on to a range of questions suggested by core participants. It's just about infection control. And this is dealt with in page 78 onwards of your report. As I understand your report, it's standard precautions are what you would apply to hepatitis C care. Could you explain what those are and what's meant by standard precautions?
Yes, so standard precautions are what we expect in any healthcare setting to protect all of our patients, healthcare users, staff from infection, be that a respiratory infection, MRSA, hepatitis C, the precaution is the same, and there are a range of standard practices that we expect every healthcare worker to practice between all patients without making any assumptions about an infection that individual might have.
So you would not expect there to be any additional precautions specific to the treatment and care of those with hepatitis C?
There is one particular area where there is a difference, and that is within renal dialysis units. And that is largely historical and dates from experience with hepatitis B, when a number of both patients and healthcare workers became infected with hepatitis B in the renal dialysis setting. And so there are different provisions within renal dialysis for hepatitis B and hepatitis C. Within that setting, hepatitis B is much more infectious than hepatitis C. And so hepatitis C patients are dialysed together as a group, but not in an isolated part of the unit in most units, although individual dialysis units may be able to offer an individual room, whatever their local provision is. So there is a difference just, I think, in renal dialysis units, and there are some differences that Professor Cooke actually wrote about in the section on assisted reproduction.
I'm just going to ask you, because you're not here tomorrow, briefly to deal with infection control within the context of HIV, because I think you wrote that part of the HIV report, yes. And but you won't be attending tomorrow. Are there any particularly significant differences between the infection control measures you would expect for hepatitis C, which, as you've described, subject to certain limited exceptions, are the standard ones, and HIV?
None whatsoever.
Then, as I say, a handful of discrete matters I wanted to ask you about. The first is perhaps best addressed to Dr. Jamieson. We have heard from a number of witnesses who relate going to see their GP over the years, reporting symptoms similar to the neurocognitive symptoms that have been described both by you orally and in the report: fatigue, difficulties in concentration and the like. Not being tested for hepatitis C, not being asked about whether they'd received a transfusion for many years, and that leading inevitably to delays in diagnosis and delays in treatment. Can I ask you to comment, obviously not on any individual case, but on that generally? What would you expect a GP to do in those kind of circumstances?
The road to a diagnosis is sometimes very straight and short. I described a case earlier that we recently looked at, which is a model, a standard, a gold standard, supported by secondary care and primary care to make sure that your lab testing, make sure that the awareness, make sure that the education is sitting at a level whereby a minor raise in a blood test is automatically cascading me to check for hepatitis C and B and HIV and lots of other diagnoses which could be possibly causing that. And a model whereby I've got access to treatments which are readily and speedily available. And I would say that model that I described, as it is now, is a model that I would say has not been, in my career as a doctor, from where I started training 18 years ago, is changed remarkably. And I would say even in the past 18 to 24 months is really where we've got to in having that type of model. The symptoms that you described are very common, and arriving at Plymouth at a train station when you were standing at Exeter might have been an obvious choice, but when you started off on that train journey in Inverness with one symptom and attending the GP, there was multiple places you could have been going with that. In fact, there were an infinite number of places you could have been going on that journey. And the symptoms that we described through, you've reflected on some of those symptoms to actually be the exact common side effects of treatments that are mentioned for the same conditions. And so trying to navigate that as a GP, I find a challenge. That doesn't justify it. I think when patients are attending and re-attending, we have to ask ourselves, is that because they've got a diagnosis of depression or of fibromyalgia or of many of the other causes of similar symptoms? With regards to the issue in particular you raise of previous blood transfusions, I think that's a really important one. I'm aware, and I've seen myself as a member of the public, the campaigns that have tried to raise that profile of the importance of that history. Only the people in the room will be able to say whether they've also seen those and whether that potentially led them to a diagnosis. I don't know, and I find that in medicine we have lots of where we think we've done the right thing with regards to raising the profile of something. The most recent one, publicly, I suppose, has been the valproate issue in pregnancy. And we've known for many years that valproate use in pregnancy could have been teratogenic, it could have harmed babies. It's only been in the past 2 years that we've really got our act together when we thought we were telling people the right thing. And the only way that we proved that we weren't was we went to patients, and the MHRA asked the patients, by the way, did anybody ever tell you that this wasn't something to become pregnant on? And it wasn't, nor by the specialists, nor by the box, nor by the summary of characteristics told them, and it said that this was a risk, but the patients didn't know when they were asked individually. And so when we think we're doing the right thing and following the right guidelines and trying to articulate the right issues, it isn't until we unpick it and actually check and go back to ourselves that we then improve that. And now I've done audits in my area, and there's not a single patient that doesn't know that that's a possibility on that drug. And yet for a long time we've known that that was a possibility. And so in medicine, to keep going back and improving our systems to try and reiterate and re-educate and make it as easy as possible to be doing the right things. The sterling work that's been done in Scotland, led by Professor Dillon and the team, to try and make sure that this work and the visibility of this diagnosis is there. I see Hep C results in my inbox on a daily basis. And that is because I am looking for it. I want to eliminate it to zero. I want to get patients offered these treatments. And the only way that I can do so is by the hard work that's been put in to make sure that it's visible to me, because of the work of a GP, 10,000 patient contacts a year or so that I might have, trying to make sure that that's at the forefront of my mind with all the other important diagnoses that I cannot miss, the cancers, the rare things, the common things, is very difficult. So I'm sorry to talk for so long and try not to give, I'm trying to give as a specific answer as I can to the question, but it's very difficult. But it's a continual effort, I suppose, is what I would highlight. And it's a continual work to make sure we're continually making little tweaks to our systems about how we can make it easier to do the right things.
Is this fair that every GP now, at least, should know that those who received a blood transfusion or blood products prior to the relevant dates fall within a category of people who are at risk for hepatitis C?
Yeah, and these patients should have been offered treatments. And the way that we've done that, trying to look through a medical record which is incomplete sometimes and is not going back, we don't automatically have a flag on your notes to say, this person during childbirth in 19 whatever received a blood transfusion. That's not an obvious thing when they're in consulting about something else. For the public side of that campaign was really important to try and highlight that. That said, if somebody was coming in and I noticed, so in my practice, when I have noticed a raise in that blood test, and I do ask the question, have you ever had a major operation? Have you ever been in a trial? Because there's these situations where patients might not have realised that they might have had it and they might have been told about it, but consenting for a blood transfusion when it was an emergency is a very different thing, and they might not have that. So it's always about looking around that and trying to make sure that we've discussed the wider possibilities of trying to unpick that. I think the the modes that we've described to try and pick up and detect Hep C with regards to the screening of the high-risk groups, the screening of the high-risk groups and the look-back exercises with regards to those that have had it. But importantly, it's the detection. The way that we're going to get the elimination to zero is the detection of those cases where they might not have known, or it might have been horizontal transmission within a household setting. Those are the cases that now I'm kind of relatively content as a GP that I'm hopeful that I know that all my patients that are at higher risk should be getting picked out. What I'm now trying to look forward at is how am I going to find that other group that are underneath that are not pinging on everybody's radar, that might have misused drugs in the 80s and don't do so now. That's those are the other groups that we're looking at. So it's very much trying to always improve.
Following on from the question, and this covers secondary care as well as primary care. Following on from the question I've just asked and your answer, again, a number of witnesses have described that whilst they're not asked the question about blood transfusion, they are asked the question in circumstances that might objectively seem entirely inappropriate to their personal circumstances about drug use, being a sex worker, having tattoos, having piercings, abusing alcohol. And many have related that being the thrust of what they are questioned about, not simply by, as I say, by GPs, but in hospitals as well, and the focus being on that rather than looking to see whether there is something in their history that may be a more obvious explanation. Does any of the panel have any observations on that?
So doctors are taught to ask all of those questions, including the blood transfusion question. And so all of those risk factors for a hepatitis or a blood-borne virus should be asked. And I know some people regard them as stigmatizing, and why would they ask me that question? But if we normalise the asking of the question and ask everybody, we can then get on to getting people tested and move forward with it. So I make no apologies for asking everybody those questions, including the blood transfusion question and the blood product question. And that's the way we will find everybody that needs to be found. And if that damages or upsets some people's sensibilities, be reassured that it's not happening to you alone, it's happening to everybody. And if someone you know hasn't been asked that question, it was because the doctor they were seeing wasn't doing their job properly.
Does it depend in part upon how the question is asked?
Exactly. There is always ways and means of asking those sorts of questions, but they should be asked.
Sorry, go on.
It's very simple to say that when you're meeting someone for the first time, I need to ask you some routine questions that we ask to all patients coming here, and then go ahead and ask them.
That's the phrasing that I use as well when I'm doing the tests themselves. I say it would be my routine practice. You have had a raise in this, but it's my routine practice to always check for these other causes to make you aware. Is that okay? Oh, absolutely, doctor. I think if we're normalising these type of conversations, that it's not stigmatising patients at the moment. I don't have pushback from that. They don't. And same with sexual health screening. It's just the exact same thing. It's my routine practice to you've asked for a sexual health screen today. What's my routine practice to also check for blood-borne viruses? Is it okay if we check for syphilis and HIV with this? Would you be at risk of hepatitis? And only by having it as routine course do you ever find all the cases.
There's then a number of specific questions I've been asked by core participants to ask. So they won't necessarily follow a particular sequence.
Well, just before we go there, can I ask one further question? It really arises out of a comment which I think Professor Dillon made earlier about the advice which a GP might give these days to someone who has hepatitis. That was that you would hope he would have online access to details, information. And I was just wondering, really, for you to deal with principally, Dr. Jamieson, how far that implies that the average GP will not know enough from is usual practice to be able to deal with that, and that may say something about the level of hepatitis that doctor comes across, or for that matter, the level he's looking for. Is there, in your experience, and I think you may have to exclude Tayside from this, but is there in your general experience of talking to other GPs a lack of information about diseases such as hepatitis?
I think that is there standardised information? I would say across the country I'm not aware that there is for general practice on things that you could automatically turn to for patients. I know the RCGP, for which I would obviously declare that I am a member, and they have worked, done work in their liver toolkit, which tries to support a breadth of resources that we could turn to. So I would say that that's probably the closest you could get to a universal source that you could turn to try and signpost you to areas where you could, if you wanted to improve your knowledge and education, you could look at specifically. If you wanted to find resources to signpost patients to, that could also be within there. Beyond that, patient information leaflets are integrated within the GP system. There are ways to access those. In most GP systems have direct access into patient information printable formats.
May I just ask, leading on from that, presumably the problem of transmitting information arises when you have, as a GP, a test which is positive, and you have to see that patient for the first time to deliver the knowledge that it is a positive test. If the GP hasn't got the information readily available in the back of his mind or her mind, but has to go online, that takes time.
It takes time.
Is there time in the usual GP practice to deal with that, to prepare in advance rather than say something and then try and catch up later?
No, is the short answer. I would say that I would hope that I would know in advance why the patient was coming in and what we were going to be discussing. With regards to the time, the UK is got amongst the shortest GP consultation lengths in any developed country in the world. 9.2 minutes is the average GP consultation in the UK versus 23 minutes, I think, in Sweden. So we do amongst the shortest amount of time, and therefore within that, I would say that in an increasingly complex, multi-morbid, and especially if we're talking about something that's an unexpected diagnosis, such as hepatitis may be for somebody that had a transfusion, many years before. I personally, would shape my day and my appointments around affording the opportunity to make sure that we could have a proper discussion about that. That obviously makes the assumption that we've known in advance that's what we were going to do. Often now, as I've alluded to, we're trying to find the cases where it might be unexpected, and therefore that might not be. But if that means I run late, well, that means I run late. So the resources are there. Trying to immediately know where to bring them in, I think, is the other challenge, as I alluded to before, that I know that they won't remember a huge amount, but I know that very quickly they'll have a lot of questions, and therefore making sure that the processes are follow-up. And often I will often say, you will immediately have quite a lot of questions. Come back to me, and we will instantly then pick up where we've left when you've got yourself to that point. And I'm fortunate in that for where we work, I work really hard to make sure that access to GPs is timely, and that's hard. And I know in all areas it's not as easy access as it could be, and that's with lack of GP numbers. But we work hard to make sure that you can get back in, especially for these types of issues, and when it's an important diagnosis, because often that conversation might just be, it might only take the 10 minutes to just explain what the initial points are, but very quickly in an IT and in an IT accessible world, when the patient is walking out the door and possibly already has access to their phone in front of them to start to look into these things, I must help and make sure that I've appropriately signposted to resources such as those we've referenced, to make sure that patients can start to look at things which have some authority behind them to start to answer some of their questions.
Dr. Jeffery, you were going to add something.
Yeah, just a couple of comments. So in my role as a consultant microbiologist, I mean, I'm dealing, as we've already heard, with the diagnosis of hepatitis B and hepatitis C all the time. But I think the important thing to remember is that for any individual GP, they may actually not have any patients on their books, as it were, with hepatitis B and hepatitis C. And something that I personally do a lot of, because GPs are a sensible bunch, if they're faced with something where they don't know exactly what they should be telling the patient, they will call for advice. And we do quite a lot of signposting to GPs, taking them through the important things to talk about, but also signposting them to written advice and often physical pieces of paper as well as online stuff, because patients don't remember what they've heard in that initial discussion. So Scott's got a lot of experience and a relatively large cohort, I presume, of patients, but there will be GPs who don't have any patients with a blood-borne virus diagnosis at all. So, and there are hopefully systems to support those GPs to support their patients. But providing signposts to good online advice is really important, and good written advice.
Thank you.
So, first of all, a couple of follow-up questions relating to ongoing screening post-SVR. Picking up on something that was said by one member of the panel earlier, when patients are being regularly screened, their cancer may not be picked up until a later stage. And the question that I have been asked to raise with you is, are there any investigations not routinely used which might assist in earlier detection, or would more regular screening make a difference?
So there's research that shows more frequent screening does not make a difference, and that 6 months seems to be the optimum interval. The reason why some cancers may not be picked up relates to the concept of sensitivity and specificity that we heard before. Ultrasound is the most commonly used type of test, but if you think back to the picture that I showed of the nodules, what we're looking for is a nodule among nodules on ultrasound, and that's why it can be very difficult to detect. There are other tests such as CT or MRI, there's no evidence to support their use in screening or surveillance at the moment, but it is very much a conversation with the patient and about your level of suspicion. So if you find something that the ultrasound can't say clearly one way or the other whether there is a problem, one of those situations where it might be where the person doing the ultrasound reports that they did not get adequate views of the liver, then you would have a relatively low threshold for doing a different type of test. But even with MRI and CT, they are not 100% sensitive or specific at picking up things, and it's simply because the nodules of cancer can look very similar to cirrhotic nodules on any test.
And then you've referred to ultrasound scans. I've been asked to ask about fibroscans and their use.
So this is one of the things that we want to talk about because we didn't cover it in the report. So a fibroscan is one of the measures of assessing liver fibrosis without the need for a biopsy, which Professor Dillon alluded to when he talked about imaging tests and blood tests to look for fibrosis. Now, fibroscan is just one of a number of techniques that can be used, and it's a measurement of the liver stiffness using sound waves to interrogate the characteristics of the liver. So that's the role of fibroscans. And in the past, biopsies were used to try and determine how much scarring was present, but because it is associated with a risk and it may be painful or uncomfortable for the patient, tests such as fibroscan or other blood tests have now superseded the use of biopsy. And so all patients with various types of liver disease might be offered one of these tests to help establish where they are along that route.
And do fibroscans play any part in the screening process and monitoring process post-SVR?
That's correct. And it's worth making the point that access to fibroscan testing is still relatively limited in some parts of the country. It's improved quite a lot over recent years, but it's clearly a tool that's very beneficial for patients. It avoids biopsies, which we've discussed are challenging, and it allows a closer monitoring often of someone's liver condition. So there has been some investment, but it's been a bit patchy, and I think still some centres struggle to offer that outside of a specialist centre. It's different in different countries, but it's an area where I think there can still be some room for improvement.
And then I'm asked whether a fatty liver is a symptom of HCV or a side effect of interferon, or neither.
Neither and both. Fatty liver is a common descriptor. Fatty liver is very common. About 40% of the population have fatty liver, and it simply describes there is fat in the liver. And that can occur in hepatitis C. It's more common with genotype 3, and interferon therapy doesn't particularly cause it or make it any worse than it was before.
Natural clearance, spontaneous clearance, is there a timescale within which that will typically occur, and if so, what is it?
6 months.
The next question on my list, hepatitis C and damage to other organs. What other organs, in particular the kidney, may be susceptible to damage in consequence of hepatitis C or treatment for hepatitis C?
So the liver is the primary organ of damage. The brain can be affected by hepatitis C. The kidney is not directly affected by hepatitis C, but can be damaged because of the formation of cryoglobulins, which cause this immune-mediated disease. And then in the report, we've listed the other associations with hepatitis C.
This is perhaps a question for Dr. Jamieson, but it may be for others. At what level of adverse liver function would a GP be expected to take action to then move to the question of diagnostic tests for hepatitis B or C, if the person is not otherwise showing symptoms or is not otherwise in a high-risk group?
I think that then depends why you're doing the test. So we do liver function testing for a vast majority of very wide varied reasons. Most commonly, I'll get liver function test results potentially for monitoring certain medications, which I know will slightly increase liver function abnormality. We might be using it in patients who have other lifestyle diabetes, cardiovascular disease, which is causing a raise in their liver function, and we're monitoring that. It might then be, you've mentioned that with the exception of the symptomatic patients, I suspect that's the area actually to focus on. That's the threshold where just now we think we need to improve, where the evidence, as we alluded to in our expert report, is changing, where we suspect that our tolerance for that higher end, remember these normal ranges, how they're created. I'm not the clinical scientist, but I absolutely see blood tests that are commonly at the higher ends of what was reported as the normal range, but the normal range is only covering a majority of the population, not all the population. Therefore, what we are now revising is actually that this normal range possibly was too generous in accepting some of the upper ranges of that abnormality, because it was missing cases of abnormalities which would go on to cause disease, and therefore we've brought that threshold down. One of the lessons that we've had to work hard on in primary care in my area is explaining to GPs that their tolerance of that higher end of liver function is now cascading to investigation and testing for hepatitis and HIV, where they might have felt that previously they might have tolerated that level within normal ranges. In fact, on the lab report that you get through, it might still say that it is normal. I suspect in the coming 4 or 5 years, and I look to Professor Dillon, I'm sure he can correct me and maybe give me an update as he likes to, that actually I don't know whether we'll be reporting those as normal for very much longer. I think that will start to change more and more as our knowledge and acceptance of that. It's very hard to put a specific number on it. It depends why you were doing the test in the first place. But it's changing and evolving. It's an area where we have improved and continue to improve.
An abnormal liver test should have an explanation, and that should trigger a series of investigations, of which hepatitis screening is one of them, to see if that's the cause of it.
Thank you. to what extent is jaundice an accurate marker of hepatitis B or C infection?
So it's not a jaundice is the excess presence of bilirubin in the bloodstream that causes people to be yellow in the eye. Jaundice is the presence of excess bilirubin in the liver, which we've talked about earlier, is the byproduct that's produced by the liver and is excreted. So that yellow colour is a sign of the liver not working properly. At an acute phase with hepatitis B or hepatitis C, we can have jaundice, as we talked about earlier on, but it's not specific to those two things. And in the chronic end-stage phases of hepatitis B or C, you can become jaundice because the liver's failing, but it's a sign of liver failure, not necessarily a sign of hepatitis B or C.
And then, again, this is a question I think that's been specifically raised with one of the recognised legal representatives by individuals here. Are venous malformations around the body known to be associated with infection with hepatitis or its treatment?
So venous malformations are usually congenital. Some of them can be acquired later in life and grow as small atrial venous malformations and fistulas, and they are normally considered congenital, and there is no good evidence of association with them. They are very common in the liver, and they are commonly detected in the liver when people are found to have hepatitis C because they have an ultrasound.
If low platelet count is a significant problem in the context of advanced liver disease, what is the significance of clotting factor deficiencies in that context?
So clotting factors are produced by the liver, platelets are produced by the bone marrow. The two of them working together cause us to clot and stop us bleeding when we bleed. If you have both low platelets and low clotting factors, you are more likely to bleed.
And it's worth emphasising. And so in the setting of advanced liver failure, then often clotting factors are part of the supportive therapy that may be given to a patient.
When did it become known that hepatitis B was sexually transmissible? I don't know whether you have that information.
I think we'd probably, if you want a precise answer, we'd probably have to go away and find one.
Yeah.
But it was certainly in the textbooks by the 1980s when I was at medical school. And if it was in the textbooks, they weren't new.
And then I'm going to ask a question which I think I've already partly asked, but there's a second part to it, to which you may well not be able to give the answer, but the fact that you can't is relevant for us to know. What is known now about the prevalence of hepatitis B and hepatitis C infection, A, in the UK population as a whole, and then B, specifically in the UK blood donor population since 1970?
So I can give you figures for Scotland. I'm not sure if you can reciprocate for England.
I can try.
Okay, so the hepatitis C prevalence in Scotland is now around 20,000 people, probably 18,000, and we still have provisional figures that the figure may have fallen to 16,000, but those figures are still being internally worked on and haven't been validated yet. And that's the impact of treatment, death, as we talked about before. Hepatitis B is very rare. Hepatitis B, in terms of active hepatitis B infection, is about 10 times less common in Scotland than that. And we are working on those figures at the moment. I don't have accurate figures for that, but at least 10 times less common.
And the second part of the question was prevalence in the UK blood donor population since 1970, which I don't know whether you would be able to answer.
So from 1991 onwards, clearly anyone who is found positive is removed from the blood donor pool, so that prevalence isn't exactly the right term because they would instantly be removed, and so the prevalence is 0 because there's no. But if you want to talk about the positivity detection rate of someone who's presenting to donate blood and is found to be positive, it's less than 1 in 1,000 at the moment, and clearly that donation is not used.
Professor Cooke.
Yeah, I mean, I think there's similar estimates of hepatitis B prevalence in England, and obviously, as we've discussed earlier, the numbers of patients with active hepatitis C are falling rapidly. NHS England started by treating approximately 10,000 patients a year since 2015, which has been successful and carried on, with numbers increasing in recent years. So tens of thousands of patients have been treated in the last 3 or 4 years, and we think there are still tens of thousands of patients left to treat. But one of the big questions that we're all grappling with is really to understand how we work out exactly how many patients are left to treat and where they are. And that's a challenge, and I think, for example, We saw the data on the numbers of tests being done, but often we don't link up the numbers of the tests to individuals, and many individuals have more than one test that can distort the numbers we see. So we're trying to learn at the moment as we go as to how many are left. In certain key groups, we have a clearer understanding, but as a population, without testing a population, it's hard to know.
And then the next question I have arises out of some evidence you gave this morning, Professor Cooke, about genotypes, and you said it was unusual to be exposed to more than one genotype of hepatitis C at once. Words to that effect.
So I think to clarify that, I'm talking in general terms rather than when exposed to blood products. And so clearly within pooled blood products, there's a greater chance of pooling different genotypes from different donors. And that can be the case that you could be exposed to more than one genotype at once.
Anticipated the question and given the answer, thank you. There's a reference in your report to occult hepatitis, and I'm asked to ask you what that is.
So occult hepatitis B is an unusual scenario. We talked about the marker for hepatitis B infection being the presence of hepatitis B surface antigen. And occult hepatitis B is a situation where you don't have surface antigen that's detectable by standard tests, but you have evidence of other hepatitis B antibodies, in particular an antibody to the hepatitis B core protein, and you have usually very low-level hepatitis B DNA, which is detectable, and that means that you have viral hepatitis B infection, and you are potentially infectious, but quite difficult to pick up. In general, the level of hepatitis B DNA in those individuals is very low, and they probably did have a much more easily diagnosable hepatitis B in the past, and this is a measure of sort of incomplete clearance.
So it's worth saying it's relatively uncommon, but
Yeah.
but it is critically important if you're screening products. You won't detect occult hepatitis B unless you do a direct test for the virus, which is usually a PCR. So tests based on testing for antibody may not detect it.
But it would be picked up by the processes of screening blood donation, because they do those direct tests.
And then if someone with a bleeding disorder has had repeated exposure to a viral load through multiple treatments with factor concentrates, does this have an increased early effect? Does it affect the speed of progression or severity because of the haemophiliac's baseline status? I don't know whether that's a question you can answer or whether that's something I would need to direct to the group on Friday.
So in terms of the evidence that we have, there doesn't seem to be an increased effect. So in terms of the outcomes compared to people who have acquired the virus in other ways and have a single infection, the outcomes appear to be similar, and it's the difference effect of genotypes, etc. In terms of treatment outcomes, once those patients are treated, they appear to get the same benefits. So there doesn't seem to be a large effect, but it's a difficult area to gather evidence in because we don't have evidence about how many viruses you've been infected with. But if you've got a hepatitis C infection and you already have 80 million copies of the virus per mil of your blood, having a few other mils of infectious virus coming in is dwarfed by what you've already got and what you're already manufacturing. So I think that's another way of looking at it.
And then is someone with haemophilia more likely to have a reduced level of resistance to hepatitis C due to a depressed immune system arising out of repeated treatment with blood products?
There is no clear evidence of an effect. Clearly, the chances of someone becoming infected must be increased because they are recurrently infected. But that's not an experiment that we would ever want to do or be allowed to do in terms of working that out. But there's no clear-cut evidence one way or the other.
And then this may be a question for Friday's group, but does the severity of the haemophilia have any relationship with the progression or severity of hepatitis?
I think the only association would be in the need for blood products and hence the quantity of exposure, which might affect the risk of getting infected and the amount of infection. But in terms of progression at that point, I don't think there's evidence to suggest that's the case.
And then final question, and to some extent we've touched on this, but it's an important matter, so it's perhaps airing it again. Does a delay in diagnosis of the order of 20 to 30 years have any effect on the usefulness, type of and success of treatment for hepatitis C, and if so, what effect?
So yes, I think is the important answer.
Yeah.
Getting diagnosed early. I know clearly getting diagnosed early now when we have the current treatments available is absolutely vital. Getting diagnosed 20 or 30 years ago would have enabled you to participate in the conversations about interferon and ribavirin, which cured many people, particularly those people who had signs of progression of disease. So I think an early diagnosis of hepatitis is very, very important.
And I think one thing we didn't draw out earlier, which is helpful, is that interferon, the success rate of interferon is also affected by the stage of liver disease. So we tended to see less good cure rates with more advanced liver disease. So that delay in diagnosis can not only lead to the consequences of infection, but certainly before the DAAs came along, it could also reduce your chance of then curing if you were treated.
And then this is the very final question. Some people have described clearing hepatitis on their second or third attempt at treatment with interferon. Is there any reason why that is the case, why it worked after 2 attempts but didn't work the first or second time? And is it possible that they might have, in fact, been cleared of one genotype but been left with another?
So there is certainly some evidence of, for instance, clearing genotype 3 and then having genotype 1 emerge, because we used less treatment for genotype 3 in the early days. It's possible that sometimes people didn't tolerate the interferon as well the first time, couldn't take as much of it, and stopped therapy early and therefore had a second treatment. So there are multiple reasons for why people would end up with 3 treatments of interferon. Clearly we had the interferon before it became pegylated, interferon before it became partnered with ribavirin, and we then had interferon before it became partnered with sofosbuvir and the protease inhibitors. So many of the people who endured 3 treatments of interferon started with native interferon, then had pegylated interferon, then had pegylated interferon plus a DAA in 2013, 2014 before the pure DAA therapies became online.
And this doesn't quite answer your question, but really only very late in the interferon era did we understand quite significant genetic differences between individuals and how they respond to interferon. And we now understand that very well, although we're not using the drug so much these days. And there clearly are some well understood genetic types that affect very much how well that interferon will work.
Are there any other matters arising out of your report, or indeed any of the questions you've been asked, that we haven't addressed that you think would be important to address?
Well, I think we all feel, well, first of all, we're very grateful for the invitation to come, and thank you for that, and we're very grateful to be able to support the inquiry in its important work. I think if there's one thing we would all like to see is that if anybody does not yet have the ability to engage with care and feels they still don't trust services, that they revisit that in whatever way that they can to try and engage with the many possible pathways into care. Particularly given the advances that we've outlined a little bit today and what's achievable, I think, with treatment. So
I'm just going to turn my back and see if there are any other particularly pressing matters, and I'm happy to say that no one is putting their head above the parapet.
Well, unfortunately, I've got a couple of questions. And the first couple are really around the question of transmission. Well, I think we will hear on tomorrow, and perhaps on Friday, but certainly tomorrow, that so far as HIV is concerned, U equals U, that is, undetectable, equals untransmissible. When hepatitis B has been treated and is undergoing treatment because it's effectively the viral load has been reduced, but it's still there, does the same apply to hepatitis B?
So transmission, if there's still detectable virus in the serum, it's still transmissible. The risk of transmission is related to the load. So the higher the load, the more likely the virus is to be transmitted. Most of the drugs will eventually bring hepatitis B down to undetectable levels and therefore untransmissible.
So someone receiving treatment should be at an undetectable level,
yes,
and that will be untransmissible.
Yes.
but we don't have quite the level of evidence that we have for HIV in terms of the studies. So there's been some quite big randomised trials in high-risk groups in HIV patients that have established that very clearly prospectively.
But the cut-off risk for healthcare workers, for instance, who are hepatitis B positive, the level for them allowed to undertake exposure-prone procedures has been clearly defined, and so that's the level at which the government perceives there is no risk of transmission.
You've told us that hepatitis C is transmissible by blood, and in practical terms only by blood. When a number of those who've given evidence went to see their GPs, they were told, and I think they still would be told, not to share toothbrushes, not to share razors, and presumably to have use protection for most sexual acts. Is the level, so far as anyone can ever gauge it, of transmission by razors or toothbrush sharing or similar, the blood which isn't cleared up and someone with a cut finger touches it, something of that sort. Is that of the same sort of level, 1 in 190,000 cases transmission, or does one simply not know?
I think it's in one of those those areas that we have an absence of evidence, partly because doing the trial to try and work that out would be very difficult to give you a precise figure. Doing the experiment would be highly unethical, and trying to capture the data as to what the risk factor was for someone's hepatitis C within the cohorts of people that you could study are difficult as well. So I think it's more theoretical. If the razor or the toothbrush is contaminated with blood and was then used, it could theoretically transmit the virus, but the rate would probably be infinitesimally small, but it would be a risk potentially.
And presumably the rate of 1 in 190,000 will, for acts of sexual transmission, will be no higher than that for the other forms of transmission, because one assumes that some of the sexual transmission would be the sort that might occur when the participants don't bring an overnight bag and a toothbrush.
So I think the sexual transmission data probably needs a few caveats. So the frequency of sex was self-reported. And so in the people that were participating in the survey, how often they estimated they had sex, as opposed to how often they actually had sex, would have an impact on the rate considerably. And so if they underestimated it by half or doubled it or tripled it, we don't know what the impact could be on that rate. So I think that's that. So it's a very small. The rate is very small, but when you're in these very small numbers, a small change will move the rate up and down by a couple of decimal points.
I think trying to tease apart those different routes of transmission in a couple or a family is very difficult. We can't tell from the virus how it was transmitted very well.
The reason I asked it in particular was because of the number of those who have been very worried about the possibilities that they might be transmitting or have transmitted to people close to them through one of these routes.
I think to help reassure that point, the early estimates of sexual transmission were taken from the reports on blood cards that people have filled in, and often people were happy to disclose a sexual partner as the risk factor for having acquired the infection rather than another risk, and that may have pushed the apparent risk of sexual transmission for hepatitis C much higher than it really is, because people had other risks that they were too stigmatized to disclose.
I see. Well, that's. I was at one stage going to ask you, Professor Dillon, to tell us more about the Tayside attack on hepatitis, but now is not the time. Now is the time to thank you collectively for what has been the most informative and authoritative day, telling us about hepatitis C. And can I thank you, secondly, individually and collectively, for taking the time and effort to come here. You may have thanked us for the opportunity, but we certainly thank you for taking it. Thank you very much. Tomorrow, 10:30.
Yes, Professor Cooke is back for another round.